we will start off very slowly to allow all of those who are currently logging on to do so. So it's lovely for all of you to join us this evening. So this is our discussion on the new NICE chronic pain guidance, and our discussion today is called NICE Chronic Pain Guidance, Help or Hindrance. And this is held in conjunction between a few organisations, one being Sapphire Institute for Medical Cannabis Education, which is the educational arm of Sapphire Medical Clinics, which is a second opinion medical cannabis clinic. The Primary Care Cannabis Network, which is a group led by Dr. Leon Barron, who is with us today, that sort of supports those who work within primary care, both doctors and other healthcare professionals, with dealing with those seeking to start treatment on medical cannabis. And then finally, PLEA, which is a patient organisation which helps support and advocate for those patients who use medical cannabis. Before we start, just a quick disclaimer that this is an educational webinar which contains general information relating to medical conditions and their treatment, and this is not a substitute for the advice provided by a doctor or other qualified healthcare professionals. Please don't use this information in the webinar to diagnose or treat a health problem, and please do speak to your doctor if you require advice about your individual needs. And just to also let you know, this meeting is being recorded, but that's purely for the benefit so that we can show this to other people later on down the line. And I think a new poll should have just popped up on your screen. We're really interested to know more about you in terms of how we can sort of tailor our discussion, both in the introduction and then also in the expert panel discussion as well. So please do let us know, which of these terms best describes you, whether you're a healthcare professional, whether you're a patient, someone who cares for a patient, or some other interested party. All right, so just to take you briefly through to tonight's structure, we're going to go through some very brief introductions about ourselves. We're going to have a discussion around what is chronic pain, how NICE develops their guidance, and then the summary of NICE guidance for chronic primary pain in over 16s, which is what the actual new guidance focuses upon. And then we'll move on to our panel discussion with some preset questions, and then also inviting questions from all of you as well. And then we'll finally leave you with some other resources to point you towards for any further information as you go forward. So starting off, I'm Dr. Simon Erridge. I'm an honorary clinical research fellow based over at Imperial College London within the Imperial Medical Cannabis Research Group. And I'm also work at Sapphire Medical Clinics as the head of research there. And I'll hand over to Lucy to introduce herself.
Hi, it's great to be here tonight. My name is Lucy. I am Advocacy Director at PLEA, Patient-Led Engagement for Access, who, as Simon said, we support and advocate for medical cannabis patients. I have both chronic primary and secondary pain myself, and I'm also a university student studying STEM. So really looking forward to this discussion tonight.
Perfect, thanks Lucy. And Dr. Mohammed Sajjad, do you want to introduce yourself?
Hi, welcome everyone. My name is Dr. Mohammed Sajjad. I'm a consultant in anaesthesia and pain management. I'm based in the Midlands, where I do my NHS practice. I also work alongside and with Sapphire Medical in the medicinal cannabis sector, and have been doing that for just over a year. So I look forward to today's discussion.
Perfect. And finally, Dr. Leon Barron.
Hello, yes. Hi, everyone. Dr. Leon Barron. I'm a GP, and I've had an interest in medical cannabis now for a few years. And I guess the primary aim of the Primary Care Cannabis Network, which is a group that I set up, is to find GPs who are perhaps open-minded to new, novel ways of treatment. And it's an interesting group because we find that their GPs are out there, and we have more and more signing up to our network who are interested in learning about cannabis-based medicines. But yeah, I mean, day to day, I'm a GP. and I do a variety of work in primary care and general practice. So yes.
Perfect, thanks all. We obviously look forward to hearing all of your thoughts on the guidance in the next hour or so. But first of all, just going to take you through a brief introduction around chronic pain and what this guidance around chronic primary pain is really all about. So we know from studies looking at the prevalence of chronic pain that we know it affects between 1/3 and 1/2 of the UK adult population in their lifetimes. And 10 to 14% of adults are thought to be affected by moderate to severe pain. In addition to the burden that pain brings upon itself, there's also obvious associated problems with quality of life and psychological distress as well. And almost a half of chronic pain patients also suffer with depression. In addition, it massively affects their social lives and their ability to work, and 2/3 of patients are either less able or unable to work outside of the home due to chronic pain. In addition to the effects on the individual, it obviously has a huge impact both on the healthcare systems and society in general. And actually just looking at the prescribing of analgesics, so pain relieving medications, in 2016, this reached £537 million. Before we move on, we obviously want to find out a bit more about what people's understanding is of chronic primary pain, and we'll touch upon this going forward. So, but yeah, if you can please complete the poll that should be popping up on your screens now to let us know how familiar you are with this term, and then we'll sort of touch upon it as we move forward as well. And before we answer that question, we'll go through about how NICE, which is the body which determines how the NHS spends its money in a cost-effective manner, goes about producing its guidelines. So on the right-hand side here, you can see a general outline of how this happens. So NICE is either commissioned by other parts of the healthcare sector, or self-commissions updates or new topics about healthcare conditions. Then this moves forward in a stepwise approach through finding out more about that topic, further developing the guidance through literature review, engaging with stakeholders such as Sapphire clinics, such as primary care cannabis networks, such as PLEA, and then they bring all of that together and create a draft guidance, which then goes back out to stakeholders, and finally, before they get a sign-off from NICE as a whole, and then it is put out into guidance to be used within clinical practice. In terms of how they develop this guidance, it takes into account two main parts of evidence. The first is clinical efficacy. Does the treatment that they are suggesting, does it work? And they largely base this upon randomized controlled trials, which is largely seen within the medical community as the gold standard in terms of how evidence is generated. In addition to that, they also look at the cost effectiveness. So how much will an intervention cost? And then how will that be affected? How does that relate to the clinical effectiveness? And how they decide this is something called a quality adjusted life year. So a quality adjusted life year of 1 is another year of complete perfect health, and 0 is a health state equivalent to death. And you can have less than 0 actually. In fact, you can have health states that are generally considered to be worse off than death in and of itself. And how NICE determines whether an intervention is cost effective is that it is usually £20,000 per quality adjusted life year. So £20,000 for every extra year of full health life gained. So to go through the guidance, it was really good to sort of get your opinions on sort of what chronic primary pain is. But first of all, if you can sort of gain your views about whether you've actually been able to review the NICE guidance in chronic primary pain as yet. It was only published a few weeks ago, but it'd be really good to sort of understand if you've had a chance to go through this to date. A number of you indicated that you're not quite sure or don't know what chronic primary pain is. And I think that echoes quite significantly around the medical community, as it's a descriptive term that isn't commonly used, actually. But how NICE and other bodies have defined chronic primary pain in this setting is pain where there's no clear underlying condition, and the impact of pain is out of proportion to any observable injury or disease. And NICE provides a few examples of this that in their guidance constitutes chronic primary pain. So that includes a very prevalent condition called fibromyalgia that we can probably touch upon a bit more in our discussion later on. Chronic primary headaches, so headaches where they're unable to find a known cause for it. Chronic primary musculoskeletal pains, so muscle and joint aches and pains. And chronic primary visceral pain. So visceral pain is pain of organs, so internal organs, so gut pain and alike. And really the NICE guidance around chronic pain really branches off into two separate fields, really. The first is guidance that already predated this, which covers specific conditions where there is an identifiable cause from either imaging or from other investigations, and this includes secondary pain conditions such as endometriosis, lower back pain and sciatica, causes of neuropathic pain, arthritis, etc. And NICE is very clear to point out that the guidance for chronic primary pain does not directly relate to that for which there already exists NICE guidance upon. So this does not supersede that of those NICE guidance that already exist in those conditions as detailed here on the left-hand side of your screen. Where they've discussed about chronic primary pain, though, is they've developed their guidance, and that really sort of is broken down into 4 main management options that they've been able to evaluate. The first is exercise programs and physical activity. And what they've recommended is that there is evidence that supports exercise programs, physical activity and physiotherapy as being a cost-effective measure. So both being affordable and also clinically effective for the patient in and of themselves in improving their chronic primary pain. In addition to that, they've looked at psychological therapy, and this is broken down into a couple of types of therapy. So it's both acceptance and commitment therapy, ACT, and also the more sort of widely known, and many of you might know this, of cognitive behavioral therapy. And both of these have been shown to improve quality of life, whilst not maybe necessarily impacting the pain felt on a day-to-day basis. In addition, there is some nuanced guidance around acupuncture in chronic primary pain. And actually, when they were reviewing the data on acupuncture, there is some very there's some evidence that suggests a very mild benefit to acupuncture. And actually, in order to be able to get the cost effectiveness within the NHS for acupuncture, there's a number of different conditions that need to be met. And actually, acupuncture services aren't really properly set up within the NHS, particularly in the community, which is where NICE suggests that this will be cost effective. So again, this is an area of the guidance that has created a lot of contention. And probably the most contentious aspect of the guidance has been around pharmacological management. And in particular, in some ways, the lack of options that they have presented both to those in primary care, such as Leon, and those in secondary and tertiary care, such as Mohammed. And what they have suggested actually is that in terms of pharmacological management, they only recommend one type of medication, and that is antidepressants. And this is across a number of different antidepressants. And whilst the evidence that they have reviewed suggests that there is an increase, improvement in quality of life, a reduction in pain, and a reduction in distress caused by pain, they were unable to suggest any other types of medications that the benefits outweigh the risks for. And they were particularly strong in their guidance about painkillers that we all have heard about and know about. So those such as opioids, they were very clear in their guidance that in their assessment, they believed that the risks outweighed the potential benefits for opioids in this condition of chronic primary pain. And in addition to that, they also talked about a number of other medications that both patients and healthcare providers will know about quite well, such as paracetamol, non-steroidal anti-inflammatory drugs such as ibuprofen, naproxen, and the gabapentinoid class of drugs, so pregabalin, gabapentin. Again, they were suggested that these should not be prescribed in chronic primary pain. So in summary, there's a lot to unpick there, and maybe now is a good time to sort of move towards our discussion with our panelists and maybe get some of their take on the guidance, and maybe also if you put some of your questions in the chat, and we can pick out some of those and put them to our panelists today. So perfect. I'm just going to stop sharing my screen so we can see you all. Fantastic. All right. So maybe if we go around and maybe just get your sort of initial thoughts, each of you as to when you sort of read this guidance and what your initial thoughts were when they came out. Maybe Lucy, if we start with you from a patient perspective.
Sure. I think the guidance, and particularly how it was communicated into the media and communicated on social media, was very distressing as a chronic pain patient to read and understand. And as the chronic pain community in general often have traumatic experiences previously with obtaining healthcare, with feeling like their pain is being believed and taken seriously and treated appropriately. So the headlines that said, only antidepressants will be offered were very, very distressing for patients. The guidance does specify that medications where patients are responding effectively already should not be withdrawn. But as any patient knows, they always feel like they are a bit at mercy to clinicians. But I think there are other aspects to the guidance that hopefully moves towards more shared decision-making, and where a patient is seen totally as a person-centered care, as we all need, and developing care plans to actually support patients. But yeah, it's definitely a bit of a roller coaster for the community, and it will be very interesting to see how it is implemented.
Cool, fantastic. Thanks, Lucy. And how about Leon? How about yourself? Leon, very classically, you are on mute.
Yes, good point. Should know by now after all these Zoom chats. Yeah, my initial thoughts when I read the guidance. First of all, the confusion around this terminology, chronic primary pain, which is not something I'd ever heard or familiar with, as would any of my colleagues when I spoke to them about it. So that was the first thing, that there's guidance based around this concept that people, a huge proportion of population will potentially have this diagnosis, that I think is really very difficult to commit to as a clinician, to give a patient that diagnosis. So that's the first thing, just the difficulty in sort of unpicking the difference between chronic primary pain and secondary pain, and how that will play out in a practical sense. And then there are some good points I took from the early parts of the guidance around the personalised care and patients being involved in the decision making and so on. But then as the guidance continues, I have to be honest, I think overall I felt it didn't really match it didn't match up with what can be achieved in practice, both in primary and secondary care. So, I don't want to, perhaps later on we'll go pick certain specific areas, but, overall, I think it was it's trying to neatly box up something that is notoriously difficult to manage. I think that's probably the best way of putting it. Chronic pain at the best of times is complicated, difficult, patient specific. So to sort of package it up in this very neat, quite a concise summary that's really based on small RCTs, I think is very difficult to kind of implement. So yeah, unfortunately, I want to try and say a few positive things about it, but overall, I don't really think it's very useful or very good.
Thanks, Leon. And Mohammed, how about yourself?
Okay, from a secondary care perspective, when these guidelines came out, I immediately sought opinions from my fellow secondary care colleagues, and we all shook our heads initially, and we still do to an extent. And I echo a lot of the sentiments that both Lucy and Leon have made already. In terms of the cohort of patients that we are talking about patients who are quite difficult to treat because of the nature of their condition. And I understand the nature of the studies that are out there and that are available for them. So I was initially concerned about the pharmacological aspect, and that's partly because there's a large cohort of people with chronic primary pain. Well, I'll come on to the definition in a minute, but there's a large cohort of these people who are on a whole myriad of drugs that they've already mentioned not to start, and that also is going to cause a lot of alarm bells with patients, and it's also going to cause a lot of confusion amongst the medical community. So it did frustrate us. Having said that, the guidance does contain some good aspects, which I didn't realize that they were going to be in there. The mention of the CBT and the ACT, etc., which we've always been advocates of in secondary care, and we work within an MDT setting. So all in all, I'd say there's some good points and bad points. Going back to the definition, I think a little confusing, because to us, fibromyalgia is fibromyalgia. It's not chronic primary pain, and there is a set way of dealing with fibromyalgia, and that's how we've done it. We try not to tell people that they have a condition that we don't know what it is in reality. We say you've got a condition that is managed in a particular way. Just like you wouldn't go through the molecular mechanism of appendicitis every time you see somebody with appendicitis. It's just one of those things. We don't know how it works, but it is what it is, and we've got to deal with it. So mixed feelings from me, but echo a lot of the sentiments that were already relayed by Lucy and Leon.
And I think you all picked up there about the definition, and Lucy, if I can bring you in here on this point, because you introduced yourself as a chronic primary pain patient. What does that definition mean to you?
Yeah, this is a newly adopted term, because I realised that ultimately some of my pain, yes, I can work out what that is probably caused by, and yes, I have a scan that explains that, but I don't have the scan that explains my skin or my whatever. And this is the thing with chronic pain patients, we are so complex. There's so many different factors affecting my pain throughout my whole entire life, and I won't be in any singular box, but and it really, what guideline do I fall under? And when you like, so many patients have such significant different comorbidities, and then you bring in mental health as well. There are just so many different things going on here that this blocking into chronic primary pain is very ambiguous, and it's lumping a lot under one umbrella. And part of me hopes that as we, you know, acknowledge it, that chronic primary pain is a significant condition in itself that can significantly impact patients' lives. I think that's important, as I think chronic pain doesn't always get the acknowledgement that it needs. But I do think, yeah, we have to be very, very careful that we're not just lumping all under one umbrella, because everybody is so different and there's so much going on in one patient that ultimately, you know, patients can be diagnosed with chronic primary pain for a decade just because a particular scan or a particular blood test hasn't been carried out, and then they all, you know, and they haven't actually had all the diagnostic procedures they needed to. And particularly in marginalized groups, you know, that is much more of an issue, and we have to be very, very careful that healthcare inequalities and quality of life isn't just further perpetuated by the fact that we're just saying, oh, this is pain without a cause and therefore we cannot use medication to manage it. I think that is one of the biggest dangers here.
Mm-hmm. And Leon, from your point of view, these discussions that doctors and patients have with each other all the time around pain, where you're unable to find a cause, they're really challenging. Do you think this guidance will help you in those discussions? Will it hinder you? Will it make a difference at all?
Well, I don't think they're going to, certainly in the short to medium term, make a big difference in practice. That's the first thing to say. And I think I've said this separately to Lucy, that I don't, you know, I wouldn't overly worry too much at this stage that you're just going to get pulled off medication. I don't think that's going to happen. So commenting on things really more from a primary care perspective, I think in terms of the guidelines, it's all well and good saying, okay, we recommend X, Y, and Z, but we have to work with that in a practical sense. And I mean, if we just took, for example, supervised exercise programs, they don't really exist in my area in the way that NICE would describe them. The same applies for acupuncture. Okay, so I've never referred anyone for acupuncture through the NHS. Acupuncture is an interesting one because NICE actually said for lower back pain, there's no evidence. And the studies they looked at for acupuncture, I think, were flawed, perhaps, but small studies, possible bias, and so on. So acupuncture, I think, is interesting. The fact you can only get 5 sessions as well, I think, is unfair for those patients that maybe find that beneficial. So that's potentially difficult to manage. We already have extremely long waits in my area for pain clinics. It can take up to a year. So if NICE is saying that we shouldn't be referring to pain management programs and we should refer to CBT or ACT, then just commenting on my locality, the community mental health services, I've ever seen them so busy. So do they want to start seeing patients? You know, take now these look, hands of GP occasions, perhaps we don't do the right thing, but, you know, make a decision. And I was taught from day one of hospital medicine, if someone tells you they're in pain, they're in pain. Okay, it's subjective, take it seriously, listen to them and try and treat that pain. And we are limited as GPs, and we don't have a huge toolbox of medications. We sometimes don't want to keep referring patients to different specialties, you know, but we do. So I tend to, you know, we tend to try and rule things out before we make firm conclusions about, as Lucy said, like, yeah, we might arrange an ultrasound or an X-ray or refer to a rheumatologist or something. But, you know, there are times where the tests will not give a diagnosis. And as I said before, the pain clinics are notoriously hard to get patients into. So medication is useful, and actually it's case specific. Some patients I know with fibromyalgia respond very well to amitriptyline or pregabalin or paracetamol and ibuprofen. Some of them don't. Some of them don't tolerate anything. Some some of them that do very well on opioids, and they've been on them for years. So this is the art of being a doctor and being a general practitioner. And when that's taken away from you, I think it eats at the very heart of what we do. And actually, guidelines like this, I think, are moving more and more away from what patients feel and what patients want and what good doctors kind of want. They don't want to be told, listen, I think there's great things that come out of NICE and guidelines, but chronic pain patients don't fit neatly into guidelines. Anyway, that's a bit of a monologue, but that's my take on it.
No, that's fantastic. Thanks, Leon. And Mohammed, you sit at the other end. You are one of the people that Leon might refer a patient onto. Do you think this is going to change your practice?
Certainly not currently. I mean, I think it would have to be a big paradigm shift in pain management practice for us to be completely following the guidelines that were set out earlier this month. It's going to be a while before things change significantly, and I agree with Leon when he says, you know, that part of the art of being a doctor is actually dealing with individuals, and to an extent the guidelines do reflect that, about decision making and shared care, shared decision making about management plans, etc. So I can't see this changing my practice from a pain management point of view at the moment. But having said that, you know, a lot can happen in the next, you know, even 5 years that would change the outlook on not just pharmacology, but outlook on psychology and physical therapy. So I'd say watch this space. I don't know yet.
Mm-hmm.
So let's see.
Right. And we've covered a lot of the negative aspects that each of you think about the guidelines. Are there any positive aspects of the guidelines that you picked out that you think are, you know, were worthwhile having been included? Leon, would you like to start off?
Well, like I said before, the patient-centered approach is commendable and should be done anyway. I think the positives to come out of this may be that we start to kind of, as Mohammed's touched upon, I think there are bigger things happening in medicine at the moment, and we shouldn't underestimate what COVID has done to healthcare. And I do genuinely believe we're going to see a shift in the way that medicine is delivered, and we shouldn't discredit the very kind of high standards of care and the governance that we have in the UK. I think it's world class, and it's important that we do have organisations like NICE and the governing bodies and colleges. But I just think that the demands on the health service and clearly there's a health economic basis to these guidelines as well. Let's not beat around the bush. There's perhaps an incentive to pull some of the community pain management programs, or potentially save money on medications that are not deemed to be effective. But clearly there's funding issues in the NHS that it's public knowledge. And I guess I'm trying to touch upon a wider kind of conversation, but I'm hoping that we see a gradual shift towards more personalised medicine, more autonomy between patients and their doctors, that patients are informed of available evidence and what might or might not work, and side effects of treatment. I think we should always embrace non-pharmacological measures, psychological therapy, exercise. These are all so important, especially for managing pain. We have to embrace those, and NICE have touched upon that, and I think that's fantastic. But I just think this is perhaps the start of a new, as Mohammed's touching upon, that we're going to be forced, and we're going to have to start to question the way we deliver healthcare and do things. And perhaps that spells the end of a 10-minute pain consultation in primary care, especially for complex patients. Maybe we need 20 minutes or half an hour for certain conditions or certain types of patients. So and perhaps these kind of guidelines and this type of trying to push doctors and patients down this road will open up some of these alternative ways of delivering healthcare.
Yeah, perfect.
Yeah, no, just to echo that, I do think, I mean, you can only hope that this builds the infrastructure of psychological therapy and improves the access to these things. Because if I went to my GP at the moment and asked for a referral, it would be a year plus to see anybody or anything or to actually help my, when we're talking about non-pharmacological treatments. And I do think, as a medicinal cannabis patient who spent a lot of time just increasing pharmacological drugs and never being communicated the risks of these medications and the risks of dependence, I do think it is a positive thing that we're having, that patients are just informed on both the positives and the benefits of all treatment. But the prohibition of those medications is absolutely not the answer to it, because prohibition just leads to patients taking matters into their own hands and accessing medications illicitly and putting themselves at harm's way and just in really, really compromised positions, because living with chronic pain is debilitating, and it really impacts every aspect of your life, and people are desperate and will take measures into their own hands so they don't feel that the healthcare service is there to support them and their needs, and that's a really big risk.
Yeah, and it's a good point, because some people that do find opioids or gabapentinoids helpful, they're very accessible through the black market. So that's something to really be cautious about when you're pulling or tapering patients off these types of medicines.
Mm-hmm. Absolutely. No, definitely.
Yeah. I mean, your question was about positive aspects of the guidance, and I'd again agree with what Leon said earlier about the patient-centered assessment and in the guidance about thinking about possible causes for the pain and investigating appropriately. I think all that was commendable. I think the emphasis on how the pain affects people's lives and their functionality, again, that was commendable. As I mentioned before, there was discussion, well, a brief discussion about ACT and CBT. We're quite big advocates on psychological therapy for chronic pain, but the accessibility is the issue, I find, particularly where I work in the West Midlands. If the accessibility is no big barrier, then I think we can fulfill some of the recommendations a lot more easily. The problem is that getting access to psychology help or physical therapy, which is completely oversubscribed at the moment from various other specialities, getting all that in place is going to be the most challenging thing.
Right, and sort of slightly the elephant in the room, but Lucy mentioned it about medical cannabis. Obviously, each of the organisations has a role within the sort of large society of medical cannabis. The guidance does refer to medical cannabis, but only to refer back to its initial guidance surrounding medical cannabis for chronic pain, that further research is required. Perhaps starting with you, Mohammed, do you think that this guidance is going to affect the way that people are able to access medical cannabis as a treatment for chronic primary pain and other types of chronic pain?
Well, as somebody who works in the chronic pain and the medicinal cannabis sector, I tell a lot of my patients that it's only a matter of time before this is available on the NHS. It's got to happen soon, because we do see a lot of benefits in medicinal cannabis with chronic pain. With the current guidance as they stand, I think the guidance is accurate in as much as it reflects that there is a lack of appropriate studies, and it falls short on directing people. But bear in mind that NICE is there to devise what's most cost effective, not necessarily what's the best treatment. And that's what you've got to think about and keep in the back of your mind whenever you're reading NICE guidance, and particularly when you're dealing with individuals. So will it impact on people seeking medical cannabis? I don't know yet, but I think I don't think it's done anything to persuade or dissuade, in my opinion. At the moment, I think it's still early days from where NICE are concerned.
Yeah, no, and I think we've had some comments on social media from patients who have commented about this talk and have said, how is this going to impact my ability to access medical cannabis now that NICE is recommending all I can try is antidepressants, whereas normally the stipulation has always been, you've tried a number of first and second line therapies before either a doctor refers you onwards or you self-refer yourself onto it to receive medical cannabis treatment. I don't know if Lucy, if you felt anything within the patient community or yourself about how you think this guidance might affect the ability to access medical cannabis.
With prescribing as an unlicensed medicine for chronic pain, there is this guidance that you should have failed 2 licensed medications for this treatment before cannabis becomes an option, and how that can now be interpreted, I guess, is open to interpretation, essentially. I do think this guidance has shown what many medicinal cannabis patients do generally say, is that the upstepping of pharmacological treatments did not benefit them ultimately. So I hope that this might allow us to see, okay, there might be alternative medications. And I also found it really interesting that antidepressants are being prescribed off license, which does show that, there is ways that we can look around these medications, and chronic pain is such a complex condition. We're not going to be looking at RCTs and licensed medications to fit this. So hopefully we can start thinking outside the box a bit more, but fingers crossed, really.
Definitely. Just to come on to some points that we've had. Thank you all very much for your comments and your questions. There was one particular. There's a question that's sort of come up as a recurring theme, and perhaps Leon, if you start with this, a lot of people are concerned that having both secondary and primary pain, how will this affect them when they go to see their GP, their specialist, and how will that affect how they are ultimately treated for both of those conditions?
Well, this is just my personal opinion. I really don't think it's, like I said from the outset, I just think it's very, very difficult to separate chronic and secondary pain. Listen, there might be a few cases, textbook kind of perhaps fibromyalgia, certain conditions that, really it's kind of very clear that someone fits into that type of diagnosis. But look, the reality is most people with chronic primary pain are going to have a secondary cause of pain at some point in their life. And also chronic pain is, patients with chronic pain also have acute flare-ups of pain, whether it's like aches and joints and specific issues. So, this isn't, human beings don't fit into these 2 groups. I think that's kind of key to this. I hope that no one ever looks at people out there as a chronic primary pain sufferer, and that's a diagnosis they take with them throughout life. Because if they do, I think we've got this really wrong. That we all suffer pain, and we all suffer different types of pain. Yes, there is clearly a psychological element to how you cope with that or how you process that. But I certainly will not be looking at my patients as primary or secondary pain patients, because I don't even want to sort of entertain that type of thinking. But I'm more than happy to send them to specialists if I feel that there's something I'm missing, or that maybe they can add to that patient's quality of life or give a different perspective on things. So that's my perspective on it. That I think everyone is always going to have, in reality, an overlap between chronic primary pain and chronic secondary pain.
I would totally agree with that. Actually, I'd say that we can't separate the two. It is very important to look for specific causes for pain. I mean, the typical example being rheumatoid arthritis, and how there are specific lines of treatment for rheumatoid arthritis, which, potentially if missed, could be disastrous for patients. But it does not mean that you treat patients in pain any different to any other patient in pain. You're still dealing with them in their best interest. So yeah, I totally agree with that.
Fantastic. And I guess as we're sort of approaching towards the end of the webinar now, I wonder if any of you have any sort of closing remarks you want to leave our listeners with, perhaps starting with yourself, Lucy.
I just hope that these guidance generally in every single aspect in physical therapy and psychological therapy and pharmacological therapy is that patients are offered all options to match their care, and that clinicians, as we have all discussed today, see a patient as their whole and patients are informed on the benefits and the risks of every single treatment option and has the access to whatever works for them and their quality of life. And that's often a combination of different treatments, and they have to be accessed at the right time and for the patient to be in the right state of mind to benefit from different therapies. And it has to be really driven by the patient and meeting their needs, and really a collaborative thing. I think that is the best way to manage some really quite debilitating conditions. And yeah.
Fantastic. And Leon?
Yeah, so in terms of the guidance itself, just one last comment to say that the number of stakeholder comments that were sent back were phenomenal, and the fact that these have not been supported by the Faculty of Pain or the British Pain Society speaks volumes. Also lots of feedback from other very well-known organisations. So that perhaps puts it in perspective, how it's been received amongst not just kind of the more radical people out there like me who are interested in other things like medical cannabis, but just amongst mainstream medicine, it's clearly kind of hit a bit of a nerve there. And I would just always encourage colleagues to just treat every patient as an individual, and to think open-minded and creatively about what might be the best options for them. So yeah, that's my takeaway message.
Awesome. Fantastic. And Mohammed, finally, no pressure.
Well, what I'd say, and the first thing I'd say is I don't think a lot's going to change. If you're a good doctor like Leon, who treat patients as individuals, as a lot of my colleagues are, and not a lot's going to change for you. Okay, and nice guidance has in the past has come and gone, and I think this is another piece of guidance which will come and go. Okay, things are moving much quicker now than they were 20 years ago. And I think there is a lot more in the pipeline, be that medical cannabis or something else. And, NICE will have to reflect that as time goes by. I think we're just at a phase where we're, looking at the options, the cost-effective options, in inverted commas, at us. And that's what and that's what NICE have come up with. And in reality, I don't think anything will change on the ground, certainly not in the short or medium term.
Perfect. Just want to thank you all for your time this evening. It's been a really fascinating discussion, and I think lots came out of it, and hopefully all of those in attendance got something out of it as well. So thank you all so much for the time. Before we go, I'm just going to share a few resources. that the attendees can sort of look at and go away and reflect on what we've discussed today, and there'll be some more information on in these places. So the first two to obviously mention is both Leon and Lucy's organisation, so the Primary Care Cannabis Network, which helps to educate frontline doctors in primary care in understanding medical cannabis, and its effect, and how that fits within the regulatory landscape within the UK, and that's obviously what we've discussed in part here today. And then PLEA, which is a non-profit volunteer-led community which advocates for medical cannabis patients and helps them to find ways in which they can access the medication free from stigma, and trying to reduce the financial barriers that are obviously associated with the treatment currently. And also from Mohammed and myself, obviously the Sapphire Institute for Medical Cannabis Education, which provides a free CPD accredited educational platform where people can go on and learn all about the basics of medical cannabis, and find out much more about the plant and how its pharmacology and how it can be prescribed. And the Sapphire Institute is in collaboration with the Society of Cannabis Clinicians, which again is a non-profit based within the US, which has a host of scientific and educational resources as well. And then moving on from plugging all of our own organisations, there are a number of fantastic resources that are available. So for those of you who are clinicians amongst us, there's the Live Well with Pain website, which gives clinician-based resources to help patients to manage their chronic pain conditions. And there's an accompanying website for patients themselves called mylivewellwithpain.co.uk, which gives them patient-friendly information about chronic pain conditions. And then there's also flipinpain.co.uk, which is a public health campaign, again, which is nice and friendly with sort of nice and easy to understand information about chronic pain and how to manage your condition. A few other extra bits and pieces. We've talked a lot about cognitive behavioural therapy, and those of you who are struggling to access this, wherever you are across the country, there's a fantastic series of books around cognitive behavioural techniques, both in mental health conditions, but also particularly related to chronic pain. It's called Overcoming Chronic Pain, and it's available quite cheaply if you buy it as used on Amazon. And then the British Pain Society, who provide specific resources for clinicians and professionals in the field as well. And finally, we would be remiss if we didn't suggest that obviously we've gone through a brief overview of the guidance today, and there's many pages of the guidance and the evidence behind it that you can read in full, so that you can get an even broader understanding of the guidance. So that's it from us. Just like to say thank you again to our panelists who have been absolutely fantastic, and thank you all for those who attended, and we'll hopefully have this available as a sort of webinar for people to watch again in the future.